everyone, and welcome to episode 31 of CCA's Medical Minute podcast, sponsored by Kroger Health. We are proud to be today with our new Director of Precision Oncology, Andy Guinigundo.
Well, thanks for having me, Steve.
Did I nail that one?
Yeah.
All right, gotcha. All right, so Andy started with us on April 1st, and Andy's joining our practice as part of a new commitment to precision oncology that we're going to be introducing. We already are introducing, actually. And so Andy comes to us with 20 years of experience, oncology, nurse practitioner experience at OHC, or oncology/hematology care, as it's otherwise known. And Andy has quite an extensive background in cancer genetics. And so thankfully, he's also a 20-year ski patroller. And so if anybody has ever seen me ski, you would know that you're probably more important to my continued existence than your cancer genetics background. But anyway, welcome, Andy.
Thank you.
All right, sounds good. So also with me today is our Director of Strategic Community Engagement, Sherry Hughes.
Hey.
You're a breast cancer survivor as well, as I think many people know. So Sherry was out last week doing some advocacy work for us on the West Coast, so it's good to have her back. Welcome back.
Yeah, thank you. We spent some time at UC San Diego's Moore Cancer Center. Thank the folks there, as well as with Pumo Biotechnologies, all on the West Coast doing some advocacy work. So I'm glad to be here, and I'm glad to have Andy here with us as well. And Andy, I guess the first question would be, what exactly is meant by precision oncology?
Yeah.
Well, I think there's a few different definitions that you could give to precision medicine or precision oncology. But I think what people refer to nowadays is really this idea of, a genetic profile for any particular patient. So what a patient, is born with, what a patient's tumor has that's specific to that person, that's specific to that tumor. And that's really, I think, what people refer to when they're talking about precision oncology.
And you know what? In the past, we didn't always have that. So this is somewhat different to most people that are listening now. So we have these new capabilities, but what has changed, I guess, in medicine in this world that kind of really brings all of this to the forefront?
It's really all the work of the Human Genome Project, really, that all that research and hours of computing, which I wonder if we had started it today, if we could finish it in half the time with the computers and technology and such. But nonetheless, all that work that was done during the 90s is now coming to the bedside, which is amazing.
Yeah, it's funny when you were talking about Human Genome Project, and I've heard that term over and over and over again, but is that what we think of as the double helixes and all that actual genetic mapping, and is that individual to a person? But I mean, the Human Genome Project had to be more broad than to a specific person.
For sure. Basically we were trying to get what is kind of a model person, someone's genetic makeup, what would be considered a normal. That's a project that really was started to be conceived of in the 80s and really started in earnest around 1990. Now they, quote unquote, declared it finished in 2003, but they've added parts, and in 2003 it was only like 85% finished, and they said, we're done, but they continued to work on that though, and really declared it almost done. Last year, where within less than 1% left, and actually. And then added some more stuff just this past January. So this is it's really an ongoing project, and we're really seeing maybe this model. People questioning is the model really the correct the correct map. But it's something that certainly something that a starting point.
And this is just something that when you said that made me think of it, is the outcome of the Human Genome Project, is that what the body looks like if everything's right, if it's correct? I mean, what's the deliverable there?
Yeah, I mean, it's kind of the theoretical ideal. Is anyone actually that? Probably not.
Yeah.
We are all made up of many. You say the word mutation and you think, oh, that's a bad thing, but there's many words to describe a change in someone's genetics. But kind of the word to just to describe a change in someone's genetics. That's not necessarily a bad thing. It's a variant.
Okay.
So I have black hair, but my wife has blonde hair. That's not I'm not a mutant compared to her. It's just a variation, and so any given person has tens of thousands or more of those variants that may be different than what the human genome model would say, but doesn't mean there's anything particularly wrong.
Gotcha. I wanted to say you're doing a good job of not being doctory. I forgot to tell you. If people are doctory, get thrown off the set. So you're doing a really good job. So, but that unfortunately that leads me to a question that might cause you to get doctory if you're not careful. So, somatic testing and germline testing.
Yeah.
And so you're starting to see those terms more and more often. And truth of the matter is that most people that aren't schooled in this probably don't even know what those are. Can you explain those?
Sure. No, when we talk about germline testing, this is a term that's kind of taken from biology, and you probably when you were studying the genetics of a wrinkled pea versus a smooth pea, you would talk about the germline. But germline is really what a person was not even born with, but really conceived with. So that's mom and dad get together, and that's what that's you.
Okay.
Right. When we talk about somatic, really we're referring to tumor, so the genetics of a particular tumor, and it's it's really what makes a cancer a cancer. It's what's different about that tumor compared to normal cells.
Okay. Is it fair to say that somatic would relate to genetic changes that have taken place since you've been born?
For sure.
Okay.
For sure. Yeah, definitely.
Okay. And Andy, what then does all of this mean for our patients who come to Cincinnati Cancer Advisors? How are we using precision oncology to help them?
Well, first and foremost, I would say that even before I walked in the door on April 1st, Dr. Lemming and Dr. Jazzy are already experts in precision oncology. But when I arrive, really I'm taking a look at every single. Our volume is not such that I can't do this. I am able to look at every single chart of every single patient who's walking in the door and see, is there some angle from a genetics, from a somatic or germline that maybe that hasn't been considered. So I definitely take that piece. Certainly, some of the visits I've sit in on, in order to someone's cancer is a cancer that is more prone to genetic variations. I will actually sit in on those visits. I've done some visits where I'm doing a more traditional genetic, counseling kind of role, one-on-one with patients. I've done that a few times in the last few weeks, even. So, so I've touched patients in many different ways since I've been here.
And before Steve jumps in, as a breast cancer survivor, I had a genetic workup, so to speak, and there were maybe 30, 35 different genetic components on my panel. But now I'm hearing that there are so many more. You can have a panel with, maybe 50 or so different genetic components. How does all of that kind of come into play after you've been diagnosed? Is there a way to go back then and look at that and say, you know what, these are some other things that we may be needing to focus on?
For sure. I think what you're referring to is really your germline testing. So again, what you were conceived with. So that actually does two things for you. It can give us some hints as far as, in terms of treating someone's particular cancer, or even guiding that person's care. So if someone, for example, had a variant, a mutation that increases one's risk of cancer, it might induce you to do a more aggressive surgery, so a more extensive surgery. So you do, for example, a lumpectomy instead you do a mastectomy instead of a lumpectomy. Okay. But I always tell people who I talk to for those sorts of visits that we're looking for, how can this help you right now?
Yeah.
But how can it help you in the future? Because none of these genes seem to really just increase the risk of a single cancer. Okay. It seems to increase the risk of a whole battery of different cancers, and the screening might change for those different kinds of cancers. And so, knock on wood, we fixed you once.
Yes.
if there's something we can do to prevent a different cancer or even this same cancer from coming back, we would want to do that. But in terms of number of genes, we can check 100 genes on a person. Now, can we always do something with all that information? Not necessarily. Sometimes you see these what we call a variant of uncertain significance, and since that's a mouthful, we abbreviate that down to a VUS. When people get these VUSs, they it's just kind of like it's something that's hanging in the ether there. It's like, this might cause cancer, it might not cause cancer.
Right.
And it freaks people out because it's like, okay, that's just back there. It may be in a gene, for example, like BRCA1, BRCA2, people always talk about, with breast cancer. You could have a VUS in BRCA, and you're just wondering, is that a cancer causer or not? Just not enough research has been done to figure that out. But the more genes you test, and especially the more obscure genes you test, you might end up with more of these VUSs because there's not as much research has been done on these newer genes added to the panel. So sometimes I like to limit the genes for that, for those situations. But sometimes people are like, I just want to know everything that's possible. What's possible to test, what might have any sort of angle, so to speak, that could help me in the future. And so we'll draw those bigger panels sometimes. Okay.
So I was I think you maybe just kind of answered my question in a roundabout way, but what would be really my final question, which was, with genetic testing, is it reasonable to expect think the way I asked this question, is it reasonable to expect a cure versus no cure? Because what I was thinking was, maybe what it would have the benefit of maybe reducing unnecessary or ineffective treatments in favor of effective treatments, but it sounds like what you're saying is that can even guide decisions that might result in a cure versus not a cure.
Oh, for sure. We're talking about prevention, future prevention. Again, BRCA is a great example. If someone has a BRCA mutation, they can sometimes end up having a preventative oophorectomy. Sorry, that's a little bit doctory.
That was doctory.
Yes, sorry. That's removing the ovaries. It's like, well, why would you do that? Well, the ovaries are much harder to screen than the breast. And so if your risk of breast cancer, of ovarian cancer is drastically increased with BRCA as it is, you might want to prevent that. But, in terms of someone who might have an advanced cancer versus an early stage cancer, we're not necessarily saying, okay, we found this particular marker, you hear this term biomarker. We found this, and boy, we think this is going to cure you. I don't know that we really think that way. We think this is an option that, it might tell us what we can use. It often will tell us what we cannot use. But sometimes, it's like you step up the bat, and sometimes you strike out, but sometimes you hit a home run.
Okay.
Yeah.
I'll give you an example. A gentleman, we had on at OHC, we had on the original trials for nivolumab, which is Opdivo. That was presented at the big oncology meeting, ASCO, in 2015. So he was on it prior to that because they were presenting data in 2015. It's 2022. This gentleman's still alive, and he has stage 4 lung cancer.
Wow.
So
Okay.
that's the promise of precision oncology, precision medicine, to be able to find something that's specific to that person's tumor, that's specific to that person in particular, that might make a change in their therapy.
Gotcha. Okay. Well, Andy, this is the first of what I suspect will be multiple segments because we could talk for hours about this.
We could.
So we'll have you back in the future, especially since you passed the test.
It's exciting, Andy.
Yeah, you didn't even need to
this is
do
really.
it. I needed a do-over. You didn't even need to do it. But so join us next week, everybody, Wednesday at noon when Bridget Wojak from Kroger Health will be here, and the topic will be the grocery as a healthcare destination. And so what we'll talk about is just the various choices and things that you can do at the grocery store that can improve one's health. So we'll look forward to seeing her here next Wednesday at noon. Look forward to seeing you all back here next Wednesday at noon. Please like and share our podcast because we feel strongly about what we're doing, and we really believe that we can improve health outcomes by doing this. So take care, and we'll see you next Wednesday at noon. Thanks.